I'm going to show another sweat gland tumour for the first year residents. It's not a difficult diagnosis, but it's always nice to see a classic example, and this one was very kindly shared with me by Dr. Antonina Kalmykova of CSD Healthcare in Kyiv. And I'm going to postulate that this most likely presented as a nodule on the scalp, because that's where most of these are found. And the histology, we have two fragments of tissue in which there is obviously a tumor present. So we'll look at that at slightly higher magnification. Now, this is actually, I'll just start by telling you that this is a cylindroma, and this is a textbook example. It's really very, very nice. Now, people sometimes have a problem distinguishing between spar adenoma and cylindroma, and there is a considerable overlap, and it's worth noting that both tumors may be found in patients who suffer from Brooks-Spiegler syndrome, which is an autosomal dominant condition due to mutation affecting the CYLD gene. This is a tumor suppressor gene, and it's located on 16q12q13, and mutation of that gene results in the patient developing large numbers of tumors, which may consist of cylindromas, spar adenomas, trichoepitheliomas, sometimes trichoblastomas, and sebaceous tumors. And the cylindromas in these patients often present in very large numbers, particularly on the scalp, where they're sometimes described as turban tumors. Now, the difference between spar adenoma and cylindroma is really quite nicely illustrated in this one, because the cylindroma is composed of epithelial islands which abut each other and interdigitate within each other to give rise to a pattern that's often described as looking like a jigsaw. And this is a perfect jigsaw pattern. So this is typical of cylindroma. It can't be anything else other than a malignant one, and I'll get back to that shortly. But I think it is fair to say that sometimes a tumor may show features of spar adenoma in some places, and in other parts show features of a cylindroma. So it's not always cut and dried, but in histology like this one, well, then there really isn't any doubt about it. Now, similar to spar adenoma, cylindroma is characterized by a dual cell population. There's an outer layer of myoepithelial cells which have hyperchromatic nuclei, and then in the center one sees these larger cells with more vesicular nuclei. It's actually, if I slightly lower the magnification, it's probably easier to see. One gets a better impression of the dual cell population at lower magnifications. And then cylindroma is characterized by excessive production of basement membrane material, type 4 collagen, type 7 collagen, laminin 5, and probably other constituents. And this results, in a way, it cements the jigsaw together, which is a nice way of looking at it. And in addition to being outside the epithelial lobules, it also is commonly present within them. And as you see there, you get these balls of hyaline material almost replacing the epithelial component. An invariable present feature in Cylindroma is evidence of ductal differentiation. Now, in this one, it was quite hard to find, but there are a number, and I put a little annotation. There's one there, as you see, Arnold. We'll look at that closer in a moment, and there's another one there, and here's a. It looks almost like glandular differentiation in this one. If we look here, we can see a well-formed lumen containing granular eosinophilic material. So I think that's probably a gland. And here you can quite nicely see the myoepithelial cells with these very hyperchromatic nuclei compared to the central epithelial cells with more obviously vesicular nuclei, sometimes containing small nucleoli. And we'll just go back to the other ones, which look more like ducts rather than glands. Here we are. Here you see that there's quite a nice, well-developed cuticle. So that's a bit more suggestive of a duct rather than a gland. Now, the only other thing to mention, there's another with a very nice cuticle there. One tends not to see much in the way of mitotic activity. As I've often said, finding one is not surprising because cylindromas grow and that they can attain very large sizes. They present clinically mostly on the scalp, the head and the neck, and can be present in significant numbers, presenting as dome-shaped erythematous or rather purply lesions. Patients with Brooks-Spiegler syndrome tend to have the cylindromas on the scalp and the trichoepitheliomas on the face. But like all tumours, cylindroma may present just about anywhere if it chooses to. Now, there are one or two points that I do want to mention, and that is some folk have examined both cylindroma and syringoma for hair follicle keratins and have identified that they're positive, and this has resulted in a different viewpoint that these are in fact hair follicle tumors. And I suppose going along with that, sometimes cylindroma may show sebaceous differentiation, and it may even show focal trichoepitheliomatous differentiation. But I think the majority of folks still regard it as a sweat gland tumor. I don't get too motivated by trying to decide what tumors come from, where they come from, or where they're differentiating towards. I think that's rather, if you like, in a way, it's old hat thinking. I think it's much better if we can actually identify the molecular basis of the tumor, and I think that gives us a firmer grip on what the actual differentiation is. And it may well be that these tumors can differentiate towards sweat glands, hair follicles, and sebaceous glands. Although I must say follicular differentiation and sebaceous differentiation in a regular cylindroma is something that's I would have thought was extremely rare. There was a field here that did, it made me wonder for a moment or two. I forgot to put an annotation. So here it is here. You see here we're getting a little bit of I suppose you'd call it clear cell change. Maybe it's due to glycogen, but I can see on a bad day, if you weren't looking too carefully, you might sort of think, oh gosh, is that sebaceous differentiation? I think I would want immunohistochemistry before I went down that pathway, but I suppose it's a reasonable thought. Now, the other thing that one must remember about cylindroma is malignant cylindroma. And now this is exceptionally rare, and it's often lumped together with malignant spiroadenoma. So you have a spirocylindrocarcinoma as a sort of a common theme. These are more likely to be encountered in patients with Brooks-Spiegler syndrome, and I've only seen a very small number, I think maybe 2 or 3 in a lifetime, and I don't know whether they were in Brooks-Spiegler or not. But the important thing to remember is that they developed within a pre-existent cylindroma. So when you see one, you'll always find a benign bit stuck on somewhere or other, which gives you the clue to the diagnosis, because the actual carcinoma may just look like a carcinoma and not give you any idea where it's coming from. And some carcinomas arising in cylindroma and spiroadenoma may show squamous features, and sometimes they may be metaplastic or so-called carcinosarcoma. I remember the first 2 spiradenal that I ever saw, which is way back in St. John's days, and these were 2 different tumours which had a background spiradenoma, but there was clear carcinosarcoma with I've forgotten, I think there was osteoid or chondroid differentiation. Now, if you were looking at a cylindroma and wondering whether there were any areas of malignancy, I think, to be honest with you, it's pretty obvious that one bit's benign and the other bit's malignant. It's child's play, but it's often said that features that would swing you in that direction are loss of the mosaic pattern, loss of the biphasic pattern, nuclear pleomorphism, nucleolar prominence, mitotic activity, lymphovascular invasion, and perineural infiltration. But I don't think, if you ever encounter one, I don't think you'll be doing that. I think you'll just look at it and say, oh gosh, there's a carcinoma and there's a cylindroma, so it's a malignant cylindroma. And that's about all I can think of to say about, or the immunohistochemistry. Well, you don't really need immunohistochemistry, to be honest with you. It's just a straight H&E diagnosis. The only things I would ever do, which is really just to get a pretty photograph, is use EMA and CEA to highlight the ducts, but it isn't really necessary. So I hope that you folk just starting out in your career have found this recording helpful. It's certainly a beautiful example, and so I think if you encounter cylindroma again, you shouldn't have any problems. So thank you very much for your attention.